COPD etiology, environmental insult to lung like long-term smoking, pollution, infection, increase the free radical and inactivation of antiprotease. Here, genetic susceptibility like alpha-1 antitrypsin deficiency, decrease lung ability to prevent damage to lung tissue. All these increase the oxidative stress, increase inflammatory cytokines and increase the protease function, leads to lung inflammation. Chronic systemic inflammation in COPD as a hypermetabolic state that consume calories, so patient present as macronutrient deficient. Continue repeated injury to bronchial tree, in infiltration of the inflammatory cells like neutrophil that leads to airway fibrosis and narrowing. Gallbladder cell proliferation, increase mucus production. Mucus trap in the airways serve as a nidus for infection like acute exertion of COPD and pneumonia. Death of airway epithelial ciliated cells, decrease the number of epithelial ciliated cells to clear away the mucus, and here increase the production of mucus. Patient present as chronic cough with sputum. Increase proteolytic destruction of the lung parenchyma and vasculature. Decrease diffusion capacity on spirometer. Decrease airway elasticity known as recoil ability to push air out of lung on expiration. Total expiration takes longer than the normal. Prolonged expiration on spirometry, FEV1 by FEV is less than 0.7. Lung do not fully empty, air trapped in the alveoli, lung hyperinflation, so increase the lung total lung capacity and vital capacity on spirometry. Lung volume means diaphragm isotonically contracted, flatter. Diaphragm does not flatten much further to generate the deep breath. So patient present breathe rapid breath and shallow breath. To breathe chest wall must be expand out more. So patient have barrel chest shape. Here you can see increase the anterior posterior diameter, so known as barrel chest. In this stage, the diaphragm must be flat. Continued respiratory effort further contract the diaphragm, pull the lower chest wall inward, that have Hoover sign, paradoxical shrinking of lower chest during the inspiration. Low flat diaphragm more than 10 posterior rib on posterior anterior chest X-ray. It does not block the X-ray beam, will appear black on X-ray film. Increase the retroesternal air space on the lateral chest wall. Here you can see increase the size of retroesternal air space. Hyperlucent lung field, decrease the landmarking on frontal chest X-ray. Increase the lucency of lung field, decrease the lung marking. Lung do not fully empty, air trap in the alveoli, so decrease CO2 remains, increased O2 remains. Hypercapnia, partial pressure of O2 more than 45 on ABG. Chronic hypercapnia makes breathing center less sensitive to the high partial pressure of CO2 stimulus for breathing and more reliant on the low PO2 stimulus, O2 retention. Give O2 carefully to these patients. High O2 may suppress the patient's hypoxic respiratory drive, decrease their breathing, and the much more increase partial pressure of O2. In hyperinflation lung, more effort needed to ventilate the larger lung. So patient have dyspnea. Permanent enlargement of the alveoli, hyperinflated lung, and bullae formation. Easily rupture air sacs. Bullae is a easily rupture air sac of the lung surface. Inhaled air leak into the pleural cavity and trapped there. Patient have pneumothorax. Decrease structural support for the airway patency, airway narrowing and collapse, airway obstruction. During expiration, positive pleural pressure squeeze on airway, increase the obstruction. Respiratory muscle must work harder to breathe. Patient have dyspnea. Turbulent airflow in the narrow airways is heard on auscultation. Respiratory present as respiratory wheeze. Decrease ventilation to the alveoli, decrease oxygenation of blood, hypoxemia, decrease PO2 less than 70 mmHg on ABG, decrease perfusion of to lung body tissue, fatigue and decrease exercise tolerance. Ventilation perfusion mismatch, high AA gradient, calculate from ABG. Chronic hypoxia, kidney compensate, increase the production of erythropoietin, increase hemoglobin and RBC synthesis. Patient have polycythemia. In this stage, patient tries to expire much higher mouth air pressure, forcing patient tries to expire higher mouth air pressure, forcing airway to open wider. Pursed lip breathing. Chronic fatigue cause deconditioning, air muscle weakness and wasting. Patient breathe with the accessory muscles as well as diaphragm to try improve airway. Tripod position, activate pectoral muscles. Neck sternocleidomastoid and scalene muscle contracted. Decrease ventilation of alveoli. Hypoxic alveoli cause the pulmonary arterioles perfusing them to reflexively vasoconstrict. Since most of alveoli in the lung are hypoxic, vasoconstriction occurs across the entire lung. Vasoconstriction increase the blood pressure within the lung vasculature, and that leads to pulmonary hypertension. Increase the workload of right ventricle to pump against the high pressure. To compensate, right ventricle progressively hypertrophies and dilate, but over time its output decrease. That leads to cor pulmonale, right heart failure in isolation, not due to left heart failure.